And here is your question. Yes, begin please. Right. If you have read and understood, kindly begin your clinical examination station. You have 6 minutes.
Good morning. I'm Dr. Ilmun Kabir. I'm one of the exam candidate. Would you please confirm your name and age? After confirming his name and age,
Yes.
then
We'll say
I will-
Michael, 37 years old. Yes.
yes. Then I will wash my hands and tell the patients, I'm going to examine your knee, which includes look, feel, and move. For that reason, I have to open your left knee up to the both knee up to the hip joint.
Very
with
good.
proper
Both knees.
privacy. With
Yes.
proper privacy, would you let me to do that?
Yes. Go
After
ahead.
his
Yes.
consent, then I will ask him, do you have any pain? If you have any pain, then I will give you analgesics before start my examination. If there is no pain, I will proceed my examination. Then at first, I will start my examination in standing position of the patient from front, back, and lateral side. I will look at the both joints alignment, flexions, is there any deformities or muscle wasting, scar, swelling, then I will go to the back and see is there in the popliteal fossa, is there any cyst, and then I will see whether patient came or support with something like crutch. Then I will ask the patient, as there is severe pain, I will not ask the patient to move or to walk. And then after that, I will request patient to lie down to proceed my further examination. Before touch the knee, I will again ask the patient, do you have any pain? If you have any pain, I will give you analgesics to reduce your pain. If he says no, then I will again ensure him that during examination, if you feel any pain, then let me know, I will stop there. After that, I will start with the back of my hand to see the temperature. At first, I will look the normal side temperature of the knee joint, right? Then I will see the affected side left knee joint with my hand above the knee joint, at the knee joint, and below the knee. And after that, I will measure the quadriceps muscles 10 centimeter above the patella. Then I will do the patellar test by simply pushing with one hand and tap with another hand. If it is negative, then I will go the bulge test. And after that, I will palpate the both joint and affected joint with to see the patella, tibial tuberosity, fibular head in the both ligament and the popliteal fossa. After that, I will ask the patient to do the flexion and extension of both knee passive actively. Then I will do by myself both joint flexion and extension. Then I will do some special test, like I will do the posterior sac sign by keep the patient in supine position and hip and knee and 90 degree, and support the heel where there is a drop down of the tibia, where it is indicate that positive sex sign is a positive sex sign, and there is PCL tear. And if then I will go for another test like anterior and posterior draw test. I will sit beside the patient and keep the knee in 90-degree flexion and feet in neutral position, and push and put my fingers behind the knee joint and put my thumb in the tibial tuberosity, and taking the joint towards me is for ACL, anterior draw test, and taking away from me is the posterior draw test. After that, I will do the Lashman test, which is for ACL. With the same, will keep my keep my one hand in thigh and another in knee joint, and do 30-degree flexion. We'll see how the measure the how much the knee joint came out. And I will do valgus and varus test for MCL and LCL, and also the McMurray test by internally rotate by internal rotation to see the
What
lateral
would you
meniscal
confirm
injury.
with McMurray test? By doing
By
McMurray test, yes.
I will patient will be in supine position, and to confirm the meniscal injury.
Very good.
By if it is internal rotated, patient will
yes.
feel pain, then it is lateral meniscal. If external rotated, then it is medial meniscal injury. After finishing the special test, I will just put his gown and say him thank you, and will confirm him that I will talk with my consultant for his further management. Then I will ask the examinee that to complete my examination, I will do ankle and hip. Yes.
Now, if you can present your case. Yes, same way. Today you examined 37 years old.
I am examining this patient.
What were the findings?
Presenting after a sports injury to his left knee. On inspection, there were no there were visible swelling, and there is no visible scar or muscle bursting or any asymmetry, and the patient had a limpy gait on the left side. On palpation, temperature was equal and temperature was normal, and there are some tenderness over the left knee joint, and there is no discrepancy in any muscles.
Yes, after examination, what are your provisional diagnosis for this patient?
My provisional diagnosis is medial collateral ligament tear.
Good. Yes. Anything else?
And any traumatic injuries.
What?
Like cruciate injuries or bony injuries.
Okay. This patient had a mobility of 5 to 110 degrees. What is the normal range of knee mobility?
It's normal range is 180 degree.
You sure?
Not
so
sure.
What are the investigations that you'll ask for this patient?
At first, I will initially do X-ray.
Okay, which view?
X-ray of AP and lateral view to see any infusions presence or not. And after that, I will ask the patient to do MRI.
Okay. If this patient wants to join again for the match, because he's an athlete and plays a match in 2 weeks, what would your advice be to the patient?
I will advise the patient that he should have some rest about 6 to 9 months. And it is 6 to 9 weeks, ma'am.
Okay. All right. What else would you advise to the patient other than rest?
Other than rest, I will ask the patient not to bear any heavy weight, and some compression bandage and some to take analgesia and elevate the limb and to follow some physiotherapy.
Yes,
And
physiotherapy for how long you'll recommend?
Up to his normal joint movement.
No, but physiotherapy you'll recommend for how long? How many days, weeks, or your time window? Okay, can anyone else jump in and answer? If we begin with the diagnosis, so what Dr. Ilmun said, any other, because provisional diagnosis, okay, differential diagnosis other than MCL, anyone else can join, can add anything else?
Ma'am, can I say something?
Yes, please.
So according to the scenario, my first provisional would be because, ma'am, just after the injury, there was knee swelling, something like that. And I'm also
Yes.
finding that. So as far I can remember, the anterior cruciate ligament actually contains the middle geniculate artery. So it after trauma to anterior cruciate ligament, there will be immediately after there kind of some kind of
Very good.
hematoma formation.
Yes.
So my first provisional diagnosis would be any kind of ACL tear, something like that.
Yes.
And though the pop sound or anything is not saying in the
Yes.
stem, I
No.
would go for then I will go for any kind of like
But there was
meniscus tear, medial meniscus
twisting,
injury. Yeah,
yes, twisting injury.
twisting injury.
Yes.
Yes, ma'am, I get it.
So,
But
yes,
swelling,
yes.
what
Swelling
we actually learned in the part,
immediately.
yeah, swelling
Yes,
actually indicates
immediately.
ACL or PCL tear,
Yes.
as the middle geniculate artery is
If
there.
there is injury to anterior cruciate ligament, Dr. Abhishek, how
Yeah,
would
ma'am.
that affect the mobility of the knee joint? Because
If
this
there
one
is,
after 2 days can mobilize 5 to 110.
yeah.
What is the normal
So,
range? What Dr. Ilmun said, is that right? Can you move your
ma'am,
knee to 180 degree?
no, ma'am. Actually, it is
can't.
which movement you actually asked, ma'am. Like the forward flexion extension, which one, ma'am? There is some kind of movement of every the range of movement. Yes, every specific movement. So if we can do the flexion, we can do as much as we can. What I can remember, like 180 degree. But what actually anterior
less
cruciate
than that.
ligament
Yes.
does, ma'am,
Yes.
whenever there is injury to the anterior cruciate ligaments, there will be giving away of the knee, because the
Very good.
lower
Yes.
part of the lower leg will be forward than the normal, because the ACL actually prevents this giving away. So whenever it is injured, there will be giving away of the knee. And in case of meniscus injury, there will be some kind of locking or something of the knee during
that can be
extension
confirmed
specifically.
with
Yes, ma'am.
McMurray test, which she said.
McMurray test. Yes, ma'am.
Okay.
She said actually.
Dr. Ilmun started examination with yes, the first special test that you did was?
Yes, ma'am.
Remember?
Posterior seg. Posterior seg.
Yes. Is it wise to start your first, once you're thinking that injury could be of MCL or ACL, to start with that one, a posterior sag sign, that special test? Would that be wise to do it in examination? Because what we have learned now, that starting from October 21, we are having patients. That means you're examining the patient in front of the examiner, right? So if you're, if this is the history given in the exam scenario, and you begin with your special test with the back posterior sag sign, would that be wise enough?
No, I think I should start with the anterior and posterior draw test.
Yeah. That's what I wanted to make you realize, that once you read question, while you're given 60 seconds to read the question, make a plan while you're reading, because questions repeat. Make a plan that if it could be ACL injury or MCL injury, because sometimes ACL injury is also associated with MCL injury as well. So they are often associated. Rarely they could be, once it's a direct hit, which is not in this case. So it can't be MCL alone, right? So make a plan which test or which special test you'll do first.
As the scenario is saying that, yes, ma'am.
Yes, please discuss. We have to discuss. We have to learn. That's why I told the stations many days ahead, because I wanted you to read them thoroughly, prepare them. And I've got a new scenario today because I wanted you to learn from it.
Okay, ma'am.
And once you begin your examination, you begin with inspection, right? Okay, exposure you told, right? And you took even the consent, right? And then once you begin with inspection, you were supposed to ask the patient to walk for you. And since it's the sport injury patient is having, patient might, in certain cases, refuse to walk. So what is given the instructions that if patient refuses to walk or if the patient is walking with the crutches, you have to note that down, right?
Okay.
And then once bell goes at 6 minutes and I ask you to summarize your case, then you have to say that patient was with the crutches or walking aid or whatever patient had, what kind of gait patient had. All right, you mentioned the scars and deformities, swelling and wasting. You mentioned that, but the first two things you had forgotten. And another thing, once you were doing palpation, you look for tenderness, you look for the temperature, you even looked for, did you ask the patient to turn around to look for the popliteal fossa masses?
Yes, ma'am.
Mass.
Yes, ma'am.
Okay, I'm sorry, I forgot. Okay, and to look for the effusion, you had to do the patella tap test.
Yes, I did it, ma'am.
Okay,
yes,
and then you had to take the quadriceps circumference as well from both.
Yes, ma'am.
Did you remember to? Okay,
and the SLR too, I guess, ma'am, to see the quadriceps extensor apparatus of the knee joint.
Yeah.
Estate leg rest. Yeah.
Yeah. And then, all right, you did the movements, active and passive, and you did remember to do it on both legs. Obviously, you'll start with the pain-free leg first and then the painful leg. So that one went well. Okay, in investigation, once I asked you to present your case and I asked you to tell me the investigations, how should you begin? Because we're doing the mock practice for the exam. So how should you begin?
Okay. I will begin with the general test like CBC.
Yes, but you can say that after taking detailed history and completing my examination, what you were going to tell me, the things that you had to do. After doing this, you'll ask for the journal test, and then you did tell me MRI, but yeah, at the end it will come. Okay, after how long after acquiring injury you should write the MRI for the patient?
I didn't get the question, ma'am.
Yes, patient acquired injury 2 days ago and now patient is with you, right? After how long would you decide that patient should go for the MRI? Is it a time decided? Is it a time which determines when you should send the patient for MRI?
I think I can send him just after the injury, ma'am.
No, right away. Why? You're doing normal X-rays, right?
Yes,
and
ma'am.
then when should you ask for MRI? Can anyone else jump in and answer?
If I suspect actually, ma'am, any kind of ligamentous injury to for definitive surgical repair, we can do MRI as soon as possible, ma'am, for this patient.
Okay, justified. Yeah, yes.
Yes, ma'am. Is if any kind of ligamentous injury is suspected, and otherwise just normal trauma. Yeah, like if the special tests are negative or it is kind of patient is not in pain at this moment, something like that. If you don't suspect any kind of ligamentous injury, we should not go for MRI as soon as possible.
Yes.
We should wait a little bit. Like if the patient improves over time, it's like
if all the tests are negative and patient is still after how long patient is still complaining for pain while walking or doing activity. So how would you decide after how long you should send the patient for MRI?
Sorry, ma'am, I don't actually have any kind of a specific time period.
6 weeks, but maybe
6 weeks.
Yes.
Okay. Yeah.
And for how long would you recommend physiotherapy?
Physiotherapy, I would recommend, ma'am, 4 to 6 weeks, as we can remember.
Very
4
good.
to 6 weeks.
Rehabilitation period. Yes.
Rehabilitation period.
Very good. And after 2 weeks, if this athlete has to attend or play a football, what would your advice be?
No, no, ma'am. That would be a no from me, and at least 9 weeks patient have to have a rest, ma'am. Then they can, he or she can start playing again.
Very good. So anyone else? Thank you, Dr. Inmun and Dr. Abhishek, all others for listening. But if anyone has any question, you better ask now.
Ma'am, as the features are showing, there is a medial cruciate ligament injury. So in case of special
Anterior,
test,
anterior could be medial as well. You have to rule it out. How would you rule out?
Yes. Okay. So, ma'am, should we mention all the special tests or should we do the specific one for the specific injury?
This is my question to you.
There is a saying, Dr. Ilmon, if you will just, if I can answer your question. So whenever you find any kind of acute injury patient, which is not given basically in the exam, but if you find like any kind of pain, any kind of swelling, and just immediate history of trauma, you will just offer that test. If the patient is saying that the patient can't do, you will not do it. Like in case of ankle injury, if calcaneofibular fibular ligament sprain, you will also not do any kind of special test. You will just think that the test is positive for that patient. You can just say that to the examiner, no problem. You will accept that test as positive. If the patient can't walk, you will just say it is a limping gait or antalgic gait. That is the thing. Okay.
One more thing, Dr. Ilmon, when you start or when you start to begin doing the special test, always inform the patient that you will be doing whatever movement you'll be doing, and then if it causes pain to the patient, then stop it immediately. Don't go ahead. Don't do it.
Okay, ma'am.
In the examination. Okay.
Madam, good evening, madam. I had some questions, if you don't mind, ma'am.
Yes, please.
Ma'am, if I suspect the injury is to the anterior cruciate ligament, then I should do the anterior droit test first and then go for MRCS test to exclude medial and lateral menisci, madam. Is that it?
MRCS test you would have to do before you go ahead with the posterior sag sign or the anterior.
Okay, ma'am. The first test should be related to...
Yes, when would you do the valgus and varus stress test?
Madam, if I suspect medial collateral ligament injury.
Yes, so about the same time after.
Okay, ma'am.
Yes.
Ma'am, and another question was, the physiotherapy should be for 4 to 6 weeks, madam.
At least, yes, at least for 6 weeks.
And when to start the therapy?
You'll start right away, like once you're subscribing rest to the patient. So then you should do it in the initial phase.
Okay, it will be actually dependent on the consultant's decision, like after doing, if they suspect any kind of trauma to any ligament, they can do MRI, and after that, after the operation, the physiotherapy can be started, or it is a like kind of any kind of just normal traumatic bruising, laceration, or any kind of just normal hematoma without any evidence of ligamentous injury. You can just, after discussing, you just say in that way, like I would like to discuss with my consultant or senior, then I will just start physiotherapy for this patient. Yeah.
Okay. If it's
thank you,
very good, Dr. Abhishek, you have pointed out.
Thank you, Dr. Abhishek.
For the management of anterior cruciate injury, what would be the, if I ask a question like this, how would you manage the patient? So what your answer would be? Because Dr. Abhishek has recently given you the answer.
Yeah.
But then you have to tell me that you'll begin with the conservative management. And if it's proven that there is anterior cruciate injury, then you'll go for the surgical management, obviously.
Yes, ma'am.
Yes, very good.
And other than that, ma'am, so what we haven't told actually, Dr. Ilmon did great, ma'am. All the points like patient had been empathetic to the patient about the pain and everything. It was really good, Dr. Ilmon. Yeah, yeah.
Thank you.
Everything.
Thank you.
And if I remember it correctly, this is the first time she's presenting, right?
Yes, ma'am.
Yes,
it's really good for the first time. Yeah.
For the
Good job, Dr. Ilmon.
Yes,
yeah.
very good.
Thanks.
Right. If you have read and understood, considering it critical care scenario, please tell me, how do you plan to manage this patient?
Yes, I will manage this patient according to the advanced trauma life support by maintaining a patent airway, proper breathing, and adequate circulation. Regarding the airway, I will speak to the patient if he can speak. So airway is patent. If not, I will look for any injury or for any foreign body and listen for the airflow and feel the airflow in and feel the airflow in my cheek. I will do a jaw.
How would you position the patient?
Proceed.
How would you position the patient? What would be the position of the patient?
I will immobilize the patient.
How?
By using a neck collar.
Very good.
And tape and taping and tape and sandbag and the tape.
Yes. And the head would be how many degrees uplift?
Yes, I will elevate the head of the patient to 30 degree.
20 to 30. Yes, good.
And put it in a neutral position.
Yes.
And then doing chin lift.
After airway and then breathing, you look for the breathing and then C, circulation. Then what would you do?
For the circle, I will start the management of if there is a raised, the patient is Glasgow Skoma 8, so I will do intubation.
Okay. This patient, when you arrived, had Glasgow Coma scale of 15, and now after a while it fell to 8. Why?
This is a lucid interval.
Yes. Can you do what is lucid interval?
It is a temporary improvement in the patient condition after a traumatic brain injury.
Yes.
After that, there is a deterioration of the patient condition and decline in the consciousness.
Okay, can you please tell me what is the pathophysiology which lies behind the increased internal ICP?
There is a gradual increase.
There
is a gradual accumulation of the blood in the extradural space, leading to increased intracranial pressure.
So what are the 3 components that influences in pathophysiology?
The 3 components are the blood and CSF and the brain, and they
Very
are
good.
regulated, and they are regulated by the Moner hypothesis,
monorocalary. Yes.
Monorocalary. When one structure is increased, there is a compensatory decrease in the other structures so that the intracranial pressure doesn't increase. But if it reach 25 millimeter mercury, there will be no compensation, and this is cause increase in the intracranial pressure, and later on, if not treated, may lead to herniation and conization.
Since you're talking about herniation and conation as well, so do you recommend, if patient has increased intracerebral pressure, would you recommend the patient to go for lumbar puncture?
For lumbar puncture?
Yes. Would be advisable? No. Okay.
No,
can you please tell me what is the normal value of intracranial pressure?
From 5 to 15 millimeter mercury.
Okay, good. That is in supine position. Okay, can you tell me what are the ways that you know about which can use to measure intracranial pressure?
Ways to measure?
Yes, please. How?
Yes.
If you can classify and then tell me.
there is invasive and non-invasive methods.
Very good. Yes.
Invasive methods, intraventricular drain. It is more accurate, and
Yes.
it is more accurate, but disadvantage is it may lead to infection, and they need the experienced hands. The other non-invasive methods like extradural probe, subarachnoid probe, intraparenchymal probe, and
okay. Can you please tell me what you understand by the term Cushing triad?
Cushing triad is the presence of high blood pressure, widened blood pressure, bradycardia, and irregular respiratory pattern.
How do you differentiate Cushing triad from Cushing reflex? In other words, what is Cushing reflex? Yes, please.
Cushing reflex. No,
okay.
I don't.
Pass. This patient is comatose, you can say, or has Glasgow coma scale 8 right now. What would you do?
Yes, I will do endotracheal intubation.
Yes.
And
so what are the benefits of intubation?
Benefits of intubation?
Yes, please.
For the airway.
And? You have to read this. Okay. Once you're doing or once you're measuring Glasgow coma scale, so what are the things that you look for? Or what are the components of Glasgow coma scale? How is it calculated?
Yes, this is the motor response and the eye response, the motor and the eye, and
verbal.
Verbal.
Yes.
Describe in detail.
Can you tell me how much is what? How much is eye-opening response and the verbal and then motor? Total is 15. So how do you calculate that?
Eye response is 4. No verbal. So yes, eye response is 4. Number if 4 is
maximum. Yes, and verbal is 5, and then motor is 6.
Yes.
Okay. Since patient you will be intubating, how would you take care of the nutritional status of this patient? With patient with head injury, how would you take care of the nutritional status?
Yes, I will start. I will correlate with the dietitian for starting the total parental nutrition, including the recommended fluids and electrolytes.
Okay. Which diuretics? Bell is gone, but I want to please, if you can answer, because we were asking very slowly. What diuretics would you recommend for this patient?
Diuretics, I will use a loop diuretic, furosemide, dose from 0.5 to 1 milligram per kg, and osmotic diuretic, mannitol.
Yes.
With a dose 0.5 to 1 gram per kg.
What is the function of mannitol? How does it help in reducing the intracranial pressure? How it helps? Yes.
By osmotic, it is osmotic diuretic, osmosis.
Yes, but how does it help? It rapidly decreases intracranial pressure. How?
By decreasing cerebral edema.
But I want you to explain it to me.
Mechanism of action?
Yes, please. Okay, you will read more because in this way it seems as if you have memorized and now you're telling me. Okay, if you'll do the CT scan of this patient, how do you expect the CT scan to look like?
CT scan may show the advantage of CT scan or finding.
Yes, findings.
yes, finding may show
When you, yes,
by
look at
convex
this,
lesion.
yes, all
Yes,
right, okay,
convex lesion, convex hyperdense lesion.
yes, and midline,
with the compression of the ventricles.
yes,
This is most likely extradural hematoma.
very good, and midline shift as well, very good, okay, good, yes. Anyone want to give feedback to Dr. Yes, anyone want to give feedback?
Hello, ma'am.
Yes.
It was
hello.
really good. Like it was Dr. Hamdi. Is it your first time or like you
Very
have performed
long
before?
ago.
Long ago. Okay.
Yeah.
It was really good. There are some questions ma'am actually asked for more traditional notes. I think you can just look go through several times, then it will be definitely improved. So nothing to be worried much. And ma'am actually asked you a question that is, what is Cushing triad and Cushing reflex?
It's
so yes, it's very common to ask to be asked in the question in the examination. So it's just that line that is a mixed vagal and sympathetic response in response to the raised ICP. Whenever there is increased ICP, there will be CNS ischemic response that will increase the sympathetic system. And whenever there is sympathetic system activation, you will find that there will be hypertension and tachycardia, something like this. But whenever there is hypertension, there will be baroreceptor stimulation and it will increase the vagal tone from the vasomotor center. Then there will be reflex bradycardia. So it's just this hypertension, bradycardia, and whenever this medulla is affected for this raised ICP, there will be irregular respiration, these three actually. And other than that, you asked most of the questions, and the management is really vast for this topic. Like you can start with I would like to manage the patient according to the CRISP protocol that includes the maintaining airway, breathing, and circulatory and disability and exposure. Then some points are given actually in the traditional notes. You can just follow that and be a little bit descriptive. Like ma'am asked you, what about the position? So why 20 to 30 degree heads up? Because to maintain the intracranial venous drainage adequately, and like to loosen up the tracheal taps and collars to maintain the adequate venous drainage. Otherwise there will be some kind of cerebral edema or thing. And ma'am asked you about like why do you give diuretics? So diuretics we given actually to maintain diuresis, so that the fluid content in our body actually get depleted and there will be the cerebral edema will be replenished, right? So this is the simple question. I think, ma'am, you asked this, right? The diuresis, it causes the renal diuresis.
I actually want him to read little physiology so that he can justify himself. And Dr. Hamdi, my request, please speak faster. I know I speak slow. I
think he will improve, ma'am, with time.
But then, yes, Dr. Hamdi, if you meet every day and we do one station every day, I think you will be able to catch the speed.
Ma'am, can you please show the CT scan, please?
CT scan, yes.
Yeah. So we had actually a neurosurgeon friend, and he actually told us that we should describe it in that way. Like it is the axial CT scan of the head showing a biconvex hyperdense shadow on the right-sided parieto-temporal region, which is causing, that is the compression of the ventricles and the midline shift. If you can just describe it in this way, it will be much better.
Yes.
Yeah.
Yes.
Dr. Ishfaq actually said, ma'am, he was working in neurosurgery, so he actually told this.
Yeah. Yes.
Yeah.
Yes. So, and this is the right descriptive way of saying
right
it.
descriptive.
You cover
everything
in one sentence, and that saves you
in the parieto-temporal region and axial CT scan of the head. That's it.
Very good.
Nothing.
Good.
Yes.
Very good. Thank
That's
you,
all
Dr.
from my
Hamdi,
side, ma'am.
and thank you, Dr. Abhishek.
Thank you, Dr. Abhishek.
And here is your question, please. right. If you have read and understood, kindly tell me what are your differential diagnosis?
So, ma'am, according to the history of the patient, my topmost differential would be it may be a case of a squamous cell carcinoma or basal cell carcinoma, or it can be a case of tuberculous ulcer or venous ulcer or solar actinitic keratosis or
Right.
vulgaris.
How would you confirm your diagnosis?
So, ma'am, I would like to confirm this diagnosis by taking a punch biopsy or excision biopsy from this sample first, ma'am. It would be my first line.
How much or how big the margins should be?
If I suspect like my topmost differential is squamous cell carcinoma, I would like to take at least 4 millimeter safety margin, ma'am.
Around the tumor, very good. Okay.
Around the tumor.
Can you tell me what is the mode of spread of the tumor if we suppose that it's squamous cell carcinoma?
So, ma'am, actually, it's 5 steps of a spread of squamous cell carcinoma. First of all, there is a localized growth and invasion to the surrounding structure of the cancer cells, and then release of this cancer's malignant cells towards the circulation. Then then survival of this cancer cell in the circulation, and then through the circulation disseminated towards the distant organ or lymph nodes, and then the arrest of this cancer cell in the capillary or venous capillary bed or the lymphatic vessels, and the growth of disseminated cancer or metastasis.
Okay, very good. How do you plan to manage the patient with squamous cell carcinoma?
So, ma'am, at first, I would like to take some history from this patient, then do thorough clinical examination of that lesion, and after that, I would like to do some investigation, like for squamous cell carcinoma, I'd like to do the excision biopsy, and according to the excision biopsy result, we can do the re-excision if it is required, like adequate depth of margin or adequate safety margin is not taken, and if there is any kind of recurrence of the tumor, we can do the most micrographic surgery, and if the surgery is not conventional for the patient, we can do the radiotherapy for this patient, or we can proceed towards the chemotherapy after the operation. And if it is a case of metastatic, it appears as a metastatic cancer, we can go for systemic chemotherapy.
Okay, can you please tell me 5 differences between squamous cell carcinoma and basal cell carcinoma?
Okay, ma'am. Basal cell carcinoma actually arises from the basal layer of the epidermis with the epidermal appendages, and squamous cell carcinoma comes from the superficial layer, first of all. And basal cell carcinoma invades the basement membrane. Squamous cell carcinoma doesn't invade the basement membrane. Basal cell carcinoma is the most common type of non-melanotic type skin cancer. Squamous cell carcinoma is less common. Basal cell carcinoma is rapidly locally destructive and barely metastasize, and squamous cell carcinoma metastasize to regional lymph nodes or adjacent or different organs. And other than that, ma'am, the prognosis of the basal cell carcinoma is far better than squamous cell carcinoma, and prognosis is bad in case of squamous cell carcinoma.
All right, you did the biopsy, and biopsy report came back and it confirmed that it's a squamous cell carcinoma. So how would you prevent recurrences of this carcinoma to happen again?
So I can do the re-excision with most micrographic technique, which includes the sequential resection followed by frozen section. Whenever there is safety margin available, we can stop the resection and we can do primary or secondary closure of that lesion.
All right. You took the biopsy, and from that site, wound is not healing and it has become infective. What kind of organism do you expect to find over there?
Most commonly, it is infected by Staph aureus.
Okay, so how would you confirm?
I'd like to take a sample from the wound and send for culture and sensitivity.
Okay, and if the report comes back that it is MRCS positive, then what would your next move would be? Okay, ma'am. If it is MRS or methicillin-resistant Staph aureus positive, I would like to follow the local protocol. I would like to inform the infection control team, if available, and the microbiology consultant. And after that, I would like to follow their protocol, and I would like to manage the patient according to the infection control protocol. And if it is a case of outpatient and there is formation of abscess, I would like to do the incision and drainage and prescribe some oral antibiotic that includes the
clindamycin, amoxicillin plus tetracycline or linezolid. And if the patient is admitted, I would, after the incision drainage, I'd like to do the regular dressing.
No, patient
of the
is not admitted. Okay.
Okay, ma'am.
So, right, after a while, the same patient comes back and now patient has development of regional lymph nodes.
Yeah.
Then what would your next step be?
If there is regional lymphadenopathy, I would like to do FNAC from that lymph node, and then I would like to wait for the cytology report, ma'am.
Okay. What advice would you give to the patient?
What advice I would like to give to the patient after the surgical excision, if there is any development of lump in future, patient should report to us immediately. And if there is any kind of lump or any kind of reappearance of the tumor again, he or she should come back as early as possible to us and report. And to take.
And if there is a pain,
if there is any pain,
yes, what would you suspect?
If there is any pain, ma'am, I would like to suspect if there is any kind of bone metastasis are present or not, ma'am.
Think more closely, because you said squamous cell carcinoma and then lymph nodes are swelled, so there could be. What is virtuous stride? When would you find it?
Okay, ma'am. Virtuous stride, ma'am, it's a state of hypercoagulability, and
yes.
It actually occurs in the presence of maybe disseminated cancer due to secretion of the tumor substances like mucin in the circulation, and it actually occurs in the background of three processes, like yes. Thrombosis can occur by the three triad actually, ma'am. They are the endothelial injury, or venous stasis or turbulence, and hypercoagulability.
Then how would you treat that? How would you manage that?
I would like to manage the patient by prescribing some blood thinners on a regular basis to prevent that, and I would also like to refer the patient towards the vascular surgery consultant if possible.
Okay, blood thinner. Once prescribing blood thinner, how do you intend to keep the INR? At what level?
So if as it is outpatient, if the patient come as an outpatient basis, I would like to prescribe warfarin for this patient, and I'd like to keep the INR between 2 and 3, and on an average 2.5.
Yes. Okay, for how long?
For at least 3 to 6 months. Yeah.
Would there be any other management that you can suggest?
For this hypercoagulability, ma'am?
Yes, if patient is a repeated case. Okay,
if there is any repeated case of hypercoagulability, I'd like to suggest vena-cava filter for this patient.
Very good. Okay. Okay, right. What are the risk factors that you would advise the patient to avoid?
So the patient has already suffered, I guess, squamous cell carcinoma. I'd like to advise the patient to avoid any kind of ultraviolet or sun exposure in future, any kind of immunosuppressive drug other than the chemotherapy one, like steroids. It will increase the susceptibility of recurrence of the cancer, and also exposure to any kind of ionizing radiation or carcinogenic chemical carcinogens, and avoid any kind of exposure to any kind of viral infection. I would like to advise the patient to be safer in future, like not to have this type of infection.
Very good, excellent. Okay, thank you so much. Anyone else?
Welcome, ma'am.